I'm afraid I don't. Okay. Thank you, sir. It's been wonderful. We really appreciate your time, and the presentation was just phenomenal. Thank you so much.
Thank you very much. Thanks for having me.
Hi, good morning. I have the distinct pleasure of introducing Dr. Laura Sterni, who is a colleague and also a friend here in Baltimore. Dr. Sterni is an associate professor of pediatrics at Johns Hopkins University. Her areas of clinical expertise include pediatric pulmonary medicine and sleep disorders. She's the director of the Johns Hopkins Pediatric Sleep Center. Her major focus is the management of pediatric sleep disorder breathing. She has edited a book called Caring for Ventilator-Dependent Child, a clinical guide. She's also the primary author of the major ATS guidelines on pediatric home mechanical ventilator. She received her degree at Johns Hopkins and also trained in pediatrics and pediatric pulmonary medicine there. She's recognized as a top doc, and she's also the person that I would send my kids to be treated if they develop a sleep disorder. And she has also been recognized by her peers all over in Baltimore and at a national and international level. She will be giving the lecture When Tonsillectomy is Not Enough, Chronic Home Ventilation in Children with Sleep Disorder Breathing. Thank you. Please go ahead, Dr. Sterni.
Thank you, Monty, so much. That was a lovely introduction, not deserved, I don't feel, but happy to see you and happy to talk to all of you. This will be a little bit different presentation. We're going to move into a different age group. The pictures will be a little cuter. So hopefully everyone can enjoy this and learn something about the challenges we are having in pediatrics with chronic home ventilation. All right, I thought I made this move, but it doesn't see. Oh, there we go. Okay, I have no conflict of interest. You guys have the accreditation statement memorized by now. All right, so in this talk, I wanted to talk about chronic home ventilation in children. I was asked to talk about that. And what we're covering is a very broad range here. So we're covering children who are using CPAP for OSA, using non-invasive ventilation, BiPAP for treatment of either OSA or lung or neuromuscular disorders. And then we're even going to touch briefly on children with tracheostomies and ventilators. And the reason we're going to cover this whole group is because this is a group that we all see is certainly in the pediatric community as sleep physicians, and that you as sleep technicians and sleep professionals see in your labs or in clinics as well. So this is a very diverse group of patients, not only because of the support they need, but their underlying disorders. Again, anything from sleep apnea to severe lung disease to children with neuromuscular disorders. What they need, invasive versus non-invasive, is support only during sleep or around the clock. And in pediatrics, some of these children may get better as they get older, whereas others may have lifelong needs or even worsen as they get older. This is a group of kids that are often at very high risk for significant morbidity and mortality. So it's a group of, again, very complicated children. They're dependent, as we all know, on very complex and changing technology. Vents change, equipments change, and they require significant support in the home from their families and often in their communities as well. So why is this a topic we should be talking about here in our conference? And it's because we've really seen a huge burst of the number of children requiring ventilatory support in the home. So when I started in sleep medicine, I don't want to admit, but say 25 years ago, you know, we had a few children on CPAP, and some of you who are in my age range will remember the huge CPAP machines we had and the trouble we had fitting children with masks. And it wasn't that huge a number of kids. But now we're seeing more and more sleep apnea in children, and more children then requiring PAP therapy when they don't respond to adenotonsillectomy. Why do we see more? Well, there's been growing awareness of the consequences of OSA in children and improved awareness in our communities. So more children were asking about snoring, and we're screening and studying children who report nightly or near nightly snoring. And then the large reason is the obesity epidemic in children. So it is real, it is happening. I see children now routinely in clinic of a size that I did not see when I trained as a pediatrician. So that obesity epidemic is leaving us with more and more children relying on technology at night. And then we have that second group of children that have very complicated medical disorders, and we're doing better at managing muscular dystrophy, cerebral palsy, and these children are living longer lives, living lives of better quality, and often that involves treating sleep-related respiratory failure or respiratory insufficiency with either invasive or non-invasive ventilation. And we'll talk about it a little bit later, but there's lots of research supporting the value of respiratory support in these patients. So let's start with obstructive sleep apnea in children. So about 10 to 15% of all children snore, and about 3% of those children have OSA. And again, there have been increasing good quality studies showing the adverse neurocognitive, behavioral, metabolic, cardiovascular, and growth consequences of children who have obstructive sleep apnea. So of course, the most common risk factor in children, I don't know if you guys can see my arrow, but is adenotonsillectomy. But we have many other risk factors in pediatrics, and they include obesity, craniofacial disorders. So here's a little infant with Pierre-Robin syndrome. This is a patient with achondroplasia who have mid-face recession. This is a young man with Down syndrome, again, mid-face flattening or recession, sometimes larger tongues. So neuromuscular disorders, again, a large group of patients with muscular dystrophy, and patients born prematurely are at increased risk for obstructive sleep apnea, possibly related to craniofacial changes or to abnormal respiratory control. So I think the first question to ask is, are our patients different from yours? So by ours, I mean the pediatricians, and I think many of you are focused on caring for adult patients. So are our patients that much different? So we had, as an example, a young lady who presented to our lab with a history of snoring and a BMI of 36. On evaluation, she was found to have hypertension, left ventricular hypertrophy, hepatomegaly, and impaired glucose tolerance. She was in the sleep lab and had an RDI of 323 events an hour, primarily all obstructive. Her low saturation nadir was 54%. She had high end-tidal CO2. The important thing to note is we only let her sleep an hour before waking her up and admitting her to the hospital to manage her very severe OSA. So we never saw REM, could have been quite worse. And she spent 48% of that brief period we let her sleep with a saturation less than 70. So clearly very severe obstructive sleep apnea. So I gave you a lot of information about this patient except one thing, which is her age. She was 5. So we have clearly a patient with very severe obstructive apnea, likely highly related to her severe obesity. And now we have to figure out the way to treat this patient, a 5-year-old, effectively. So a young lady who can't understand the importance of PAP, was going to rely on her family to institute this therapy. And so these are some of the little extra challenges we face in pediatrics. So who requires PAP for treatment of OSA in pediatrics? Well, 80% of otherwise healthy kids are cured by adenotonsillectomy for their obstructive sleep apnea. But the children who require PAP are then the children with significant OSA who fail or aren't candidates for surgery to begin with. So who fails? It's the patients with very severe OSA. So I will tell you with that patient, we didn't think it would cure her, but we did take out her tonsils first, hoping that if we could even cut her AHI in half, she'd be better off, because we knew it would take us a while to get PAP instituted. But that's it's a high risk thing to even do surgery on a child that severe. But so patients who are very severe often don't have a full response to adenotonsillectomy. If they're older, probably because their tonsils and adenoids aren't that big. If they're obese, or they have craniofacial or neuromuscular abnormalities. So again, other factors that contribute to their OSA that we're not going to fix by taking out their tonsils and adenoids. Adenotonsillectomy is still the first step in these patients because you can often make it better, maybe eliminate the need for PAP, but these are the children who are most often looking at a need for PAP. And there you can see, based on some of these risk factors, that there is a high number of children who end up on PAP with physical or intellectual disabilities, sort of increasing the challenges there. In some studies have shown that up to 25% of children requiring CPAP actually have a genetic disorder or an underlying disorder. So again, it adds a little extra challenge. So this is some of the challenges we'll look at, but the first is parents, a blessing, sometimes not, developmental stage or understanding, the fact that they sleep more than adults. So we're actually asking them to wear some of this equipment for longer periods of time. And then the equipment itself, finding the right interfaces can be a problem in children. They're significantly better over the years. So when we think about compliance in children, we're not any better than looking at compliance in adults. A third of pediatric patients, when you look at sort of a number of studies across the board, placed on PAP do not continue with PAP. And PAP duration on nights used, again, just like in adult patients, is highly variable. Adolescents are the most challenging, as they are in many things. And the question is, what is acceptable compliance in a pediatric patient? So later I'm going to show you some studies of programs that have been used to improve PAP compliance in pediatric patients. And mostly as compliance, we're still using the adult criteria, so greater than 4 hours a night on greater than 70% of the nights as sort of our guideline. But again, remember, children sleep a lot longer. So whether that's even an appropriate line to think about it is a question that we have in pediatrics, but it's often what is used when we're looking at compliance. This is just a very recent study, actually it just came out a few months ago, looking at positive airway pressure in the treatment of OSA in infants. And I just throw this in here to point out some of the things we've known in pediatric OSA and treating it with CPAP. This study compared the treatment of infants, and I love this picture, both dad and baby. I don't know if you can see it. It was taken from the paper, but on their CPAP at night. But they looked at the treatment of infants with OSA versus school-age children. These were children aged 5 to 10 years with PAP. And as we've seen in studies over the years, PAP can be well tolerated by children and is effective. They didn't find really a significant difference in the compliance in infants and children. So for greater than 4 hours of use on 75.5% of the nights in infants and 61.2% of the nights in school-age children. So not a significant difference. Interestingly, there was no significant difference in the duration of use either. It was about 6 hours when they looked at what they were actually achieving, which for an infant is really not a huge amount of sleep time. So while compliance using those guidelines that are often used in studies looked fairly similar, the infants had the same duration as the school-age children, which probably is actually resulting in a lot less treatment. For the kids who had trouble, behavior was the biggest compliance barrier, and we're going to talk about some behavioral strategies. And this study reported that the challenges were finding devices and masks to use in younger patients, the irregular sleep patterns the infant has. We run into this all the time when you're trying to use a non-invasive device in a patient who naps twice a day and then sleeps on and off overnight. And really the lack of normative data, like to know where we should be shooting for as far as treatment, especially very young infants. So what are the barriers to CPAP use in children? Well, the first thing we're going to talk about is the physical side effects of PAP use and sort of trouble with equipment with PAP use. We're obviously dealing with, especially in very young children, a lack of understanding of the condition or the importance of PAP use. So you often are not trying to convince the patients about why they need to use PAP, but instead the whole extended family. So really modifying the caregiver's beliefs about PAP is important. In older children, there's the emotional factors that figure into it. Being an adolescent is tough enough, but being an adolescent who worries about going to slumber parties with PAP on or going to college wearing PAP can be very challenging. And then younger children often fear the mask or the equipment. Obviously behavioral issues associated with all of that too. And then lack of social support has been found to be a big barrier to CPAP compliance in children. One of the things that has been found to support use is a higher maternal education level. And then also parenting style appears to be critical. You know, there are parents that choose as their parenting style to be very hands-off, encourage independence early. Well, that may work for some things, it tends not to work for PAP. Whereas parents who are a little bit more sort of hands-on seem to do better with PAP use. So a lot of different things to consider, and again, not just the patient, but the entire family. So let's talk about pediatric considerations for PAP equipment. So we can order CPAP and BiPAP similar to any patient. But if our patients are too small, if they're younger children, we actually have to use ventilators like the Trilogy or the Astral to deliver the PAP because standard CPAP or BiPAP machines aren't usually approved for smaller or younger children. We, of course, are always working to find the appropriate size and fit of a nasal interface and headgear, and we really want to try and support the preferred sleep position. Part of that is because we can't, it's hard to tell a child that, listen, you really need to stay on your side all night or stay, stay on your back. It's a little harder to teach a child that than maybe an adult. We don't use full face masks in our clinic at all. That may not be universal, but we worry about, so especially younger children tend to be more spitty, more reflux. Children often can't remove masks. Children, especially using PAP, again, I've told you there's a lot of genetic syndromes, neuromuscular disease, often have trouble removing masks. So we worry about the risk of aspiration with a full face mask. On top of that, we just feel like, as many of you in the audience support, that nasal masks are likely more effective in the treatment of OSA. Of course, humidification is provided to make it more comfortable, just as it is in adults. And then we do really close follow-up to prevent skin irritation and breakdown. We've learned a lot about treating children with PAP over the last 10 to 20 years. We have to teach families, again, you have families who encourage independence and families who are just going to get that PAP on for every minute of sleep. And we have to really teach people not to over-tighten. Masks don't need to be slammed on. We teach them about appropriate cleaning to help avoid skin problems. And in many children, we often use barriers at the sites where the masks are, Duoderm or gel pads to help prevent breakdown. They have, especially younger children, very delicate skin. So we're very careful about following this up because it can really prevent PAP use. We have some special challenges at times in children too. So this is a young patient of mine who has really this wild orthodontic device, and we had to readjust her mask. I think this is her old mask. We've ordered her a different one to get out of the way of this bar that she's had in place now. Eventually this goes into her mouth. She was just kind of showing me a picture of where things were. And this is a young patient of mine who wears this helmet to correct head shape. And we had to work to figure out the headgear and how to place the hose so that he could wear his PAP with his helmet in place. Another complication that we related to equipment that we saw in children fairly, I thought, regularly early on, but has become much better, I think, with some of the changes we've seen in the nasal masks, in particular the movement away from the gel mask to these more inflatable cushions that are, I think, a little softer on the face, was that the mask, or having pressure from the mask, may cause the development of mid-face hypoplasia or flattening. This was seen more often in children who were using the mask for longer periods of time. And as we know, again, even children with OSA are sleeping much more than adults, and if they're compliant, wearing the mask much more than adults. And then on top of that, we're dealing with immature skeletons, so maybe more responsive to having this pressure on all the time. What we do is assess regularly. So we see our CPAP patients, every 4 months or so, 2 to 3 times a year at least. And just we don't have good ways. There's nothing really ways of measuring. We don't do x-rays or things, but just kind of look at the face. Think about alternative masks. Like some of our patients actually switch masks from time to time so that we're changing the pressure points on the face. Again, we counsel families to avoid over-tightening. And there has been a study, at least one study from France, showing that in children who stop support, you may see improvement again of this flattening once you don't need it anymore. But many children do continue to need it, so we try to work to avoid that, again, by appropriate equipment, avoiding over-tightening, and sometimes changing interfaces. So we've talked about some of the equipment issues, so I thought now we would move on to thinking about the best ways to institute PAP as far as support in clinic and how we teach families and children about PAP. So this was a study done at CHOP where they compared sort of a standard of care for initiation of PAP in children to a very intensive CPAP program. So the standard of care was actually very similar to what we still do here, which is they had an initial clinic visit where they introduced PAP. There was a visit with a physician then and a nurse educator. And then they would order the PAP, and it would take some number of weeks to get the PAP. They would do a follow-up clinic visit, again, with the physician and nursing, and then move to the titration sleep study. So with that standard of care, 68% attended this follow-up clinic visit, and only 38% completed the titration visit. In their intensive program, they did a number of things. One was they actually added an RT to the initial training and initial clinic visit. And there's an independent study also from another institution showing that RTs maybe early in this educational process do add value. They actually provided the equipment. They worked with a DME company and provided the equipment in clinic. They did a follow-up phone call very shortly after that, a follow-up visit, and then a titration polysomnogram. And I think the time frame for this was a bit more compressed. And with that, they obviously had much more success. So 81% attended the first follow-up visit, again, compared to 68%, and 84% completed the titration study. So their compliance, again, the 4 hours on 70 was 64% for the first night. So that's excellent. And then 24% achieved excellent compliance. So over 80% of nights for over 6 hours. So they did have some success with it. They had good success with this very intense program. But their really goal was to analyze the cost. It clearly was more expensive. Not covered by Medicare, but given the insurance mix they had at their institution, they did find it affordable there. So took a little sort of ways of thinking about how to support RT and nursing and all this support in clinic. But you can see with this intense approach, they did have a good response in compliance. Similarly, this is a study that was done in France, where in Europe, inpatient institution of CPAP therapy, so when they wanted to start CPAP was a patient, was actually the norm, apparently. So they would admit children, and they would have a 2 to 3 night visit. And this was piloting an outpatient program. So with the outpatient program, very similar, where they had a 2-hour initial visit with education. They actually had the mask placed in clinic, and then did 30 minutes of low pressure in clinic. So mask placed with the child and turned it on. Then they had home visits. And again, you can see how intense this is, by a trained educator in 3 days and weekly for the first month. And then we're able to do in-home titration fairly early, so before 2 months, clinic monthly for 2 months, and then every 3 months. So very, again, very intense. And they had 80% of subjects achieved excellent compliance in 2 months. So their suggestions were that you need close follow-up and monitoring. They also, their population was mostly with complex medical conditions and children with obesity. And they were interesting. They admitted that their compliance was much higher than had been reported in many other studies. And they thought, one of the things they thought was that this may have been a difference with the approach of French parents, that somehow French parents were more able to convince their children to use CPAP. This idea, though, that the early weeks or months are important has actually also been supported in the literature and other studies, that really hopping on it, getting good compliance right away really predicts better compliance in the future, which I suspect is the same as in adult patients. Not moving anymore. Let's see. Okay. In all of these programs, and as part of almost any initiation of PAP therapy in children, behavioral therapy approaches are almost universally used. So when you think about starting PAP in a child, you're often thinking about a very gradual introduction of mask and machine. So, you know, often people ask us about split night studies, and we don't do split night studies in our lab for 2 reasons. One is most children will be treated by adenotonsillectomy. And the second is even if you're pretty sure the child won't be treated by adenotonsillectomy, very few children like to be woken up in the middle of the night and have a mask slapped on their face. And it's usually not the way we want CPAP to be introduced. So in the most resistant children, you may be going through, you know, mask as a toy, mask are placed on toys, then your mask is on awake while you're watching your favorite video or game, and you kind of gradually increase time. Then mask on with machine on, mask and machine with sleep, start with lower pressures and gradually increase. So this is the kind of approach we're doing frequently in clinic. We have a nurse who follows up with patients. Great, you know, now you're at 20 minutes while you're watching SpongeBob. Let's try 20 minutes as you're going to sleep. So it's, again, a very gradual introduction for most patients. Rewards work in children. This was just a study where they looked at a table of sort of charting use and rewards. And the only reason I put it there is I like child number 3. Everybody else is like, go to a swimming pool, get a toy. But number 3, he got a visit to the zoo and a toy. He also chose his night without CPAP. So he's a good negotiator there, I think a future lawyer. But rewards work. We use them frequently in children. And then we will say, think about how well the titration study is going to go. We want them to be wearing it at least enough that they'll tolerate it. And then also we don't want the titration study to be threatening. So if a child you think is going to have trouble touring the lab, meeting with our lab psychologist to get used to the equipment, basically you want everything to be as non-traumatic as possible and as positive an experience as possible. So in summary, when we're thinking about PAP compliance in children, educational programs and working with educators in clinic, our nurses, our RTs, our PAP educators is important. And we want to educate both the children to the level that's appropriate and the parents. You want to work on appropriate equipment and settings. So again, we do try to think about our titration studies earlier than we used to, because sometimes having the right pressures also helps children tolerate it better. Multidisciplinary teams across the boards have been shown to be beneficial. In older children, when possible, peer groups, talking to someone else who uses it can be very, very helpful. Close follow-up and reinforcement in the early weeks appears to be critical. And we just need to remember that the average time to acceptance in children is often measured in months, not days and not weeks. So it's a slow and steady kind of issue. We sometimes come up against insurance because of this, but we're usually able to allow children more time to become accustomed to using PAP nightly. So once you have a child who's using PAP and is well established on PAP, when else do they need a sleep study? Well, basically the natural history of OSA in children is not well established. And there's a number of factors that will influence PAP requirements, of course. The course of their underlying disorder, if things improve as they get older, if an infant is very hypotonic, but that's going to get better as they get older, they may not need PAP as they get older. If things worsen, they may need more pressure. Growth, which includes changes to the upper airway structures, will change requirements, and weight. So if children gain a lot of weight, that will not be helpful to their need for PAP, but if they lose a lot of weight, that may eliminate it. So typically in children, studies are recommended yearly as sort of the average, but we tend to do maybe more often than yearly in an infant or a young child, and maybe less often in a stable adolescent who's not growing or having dramatic weight changes. But I think a good guideline, at least to think about in my mind when I'm in clinic, I think about, do I need one this year, and discuss that with the patients, and certainly with any change of symptoms or concerns. So this was a really interesting study, I think, that supports the need for repeat studies in children who are stable or appear to be stable on their ventilatory support. So this was done in Australia, and they took 42 children with OSA or hypoventilation related to lung disease who were established on ventilator support. This was non-invasive ventilation, so a mix of CPAP and bilevel. And after sort of a yearly polysomnography, changes were recommended in the settings for 65% of the CPAP group and 36% of the bilevel group, so not an insignificant number. And then they sort of just watched to see if the changes were actually carried out. And they were variably carried out by the time of the next yearly study. So sometimes the changes had been made and sometimes the changes hadn't been made. And it came down to something like almost half. And basically, when they looked at the groups, the scores on quality of life scales improved significantly in the group where the changes were made. So the conclusion was, and it's something I keep in mind when I'm at, is that the yearly study was useful, and when it was acted upon, seemed to lead to better treatment and an improvement in in symptoms. So something newish in pediatrics is the use of auto-titrating CPAP for the children, the treatment of obstructive sleep apnea in children. So auto-titrating CPAP has always been sort of an open question in peds. As you all know, each different manufacturer uses different algorithms to have the machine determine which pressures will be used. And there was concern that these machines might not adequately pick up sort of respiratory effort in children, the tidal volumes in children. And so it hasn't been widely used yet in children, but you are seeing it more commonly, in particular in older children and adolescents. And this was a study that came out last year. There have been a few, not a lot, looking at auto-titrating CPAP in children. And they looked at 3 of the different pressures you can get from the machine: the pressure mean, the mean of the peak pressure, and the mean of the pressure 90% of the time. And they found that when you compared that to standard titration, 68% of the time you were within 3 centimeters, which is good. But you can see there were outliers on both ends. So this is the peak mean, which we'd expect to be lower, because there's times where the machine allows it to drop, but you'd expect the pressure of the peak, so this is the mean of the peak pressure, and the pressure 90 to be close to your titration study. And you can see that there's still, in some places, a big difference, where it was lower by 6 to 8 or sometimes higher, which may have reflected an incomplete titration of your laboratory study. So while we think there's a good use for auto CPAP in some children, and like I said, we are definitely using it more in our clinic in older children, they really still require close follow-up, sort of looking at symptoms and thinking about laboratory titration if you feel like you're not getting a good response to treatment, or the patient still has concerns about how it feels. Because again, I think it's still not quite as well studied in children, although we're seeing more data. So there's some other modalities that we're starting to see a little bit more commonly in pediatrics as well. And one of them is the high-flow open nasal cannula system. So several studies have shown that high-flow nasal cannula can be successfully used to treat OSA in children who are resistant to PAP. And we're finding it useful in some of our very young OSA patients where really finding a PAP device can be difficult. This seems to be better tolerated and maybe a little bit more useful for longer term periods. As many of you know, the device delivers heated, humidified air through a cannula that only occludes about 50% of the nostril. There are only a few small studies, but it's been used across the severity spectrum with, success. And the compliance tends to be good, not much different than the nasal cannula. We don't have a good way of measuring it, though. The machine doesn't give us sort of the detailed printouts that you may see looking at CPAP machines and BiPAP machines. So how does it work? Well, certainly in older children and in adults, the increase in pharyngeal pressure appears to be quite modest. There is some thought that maybe in younger children and infants, given the fact that the nares are smaller and there's a relatively larger size of the cannula compared to the nose, you actually may be getting more real pressure. But it does not appear to be the same pressure that would be delivered with PAP, of course, because it's a more open system. It may increase lung volumes, though, and improve reserve and upper airway patency. And people have also postulated that stimulation of the upper airway muscles and the responses there may help improve airway patency. There are no standard protocols for the treatment of, for example, obstructive sleep apnea or respiratory insufficiency with high-flow nasal cannula. I think one of the bigger studies was done in Colorado, and they sort of suggested in younger patients who are using the junior system, starting with 5 liters per minute, and older patients 15. The max on the pediatric cannulas is 20 liters per minute, and it's 50 liters per minute on adults. So, you know, it's very much still a work in progress. It is something we've used a few times here and are starting to think about more. But it does appear to be useful in some patients who either would be a challenge to start on CPAP therapy or seem to be intolerant to CPAP therapy. I actually had a recent case where we used high-flow nasal cannula. It was a very interesting case that I thought I would show you today. And this was, we used high-flow nasal cannula in a patient with infantile hypophosphatasia. So hypophosphatasia is a very rare inherited metabolic bone disorder. And when it's recognized at birth, it's because of the lack of skeleton mineralization. And in early, years ago, not even that many years ago, it was fatal in infants. So I want to show you, so this infant, this is his skull with infantile phosphatasia. And this patient was just born of, I think he's about 6 months old now or 7 months old. And so this is normal mineralized bone, and this all is not. So he should not have this very clear looking skull. And then along with that, they have rib abnormalities, and they have what's called gracile ribs. So they're very thin and delicate ribs, and so their chest wall is very compliant. So like I said, this disorder not so long ago was fatal for infants, but now there's an enzyme replacement therapy that literally allows them to build bones. It's, for those of you who are Harry Potter fans, it's quite Harry Potterish. I don't know if you remember when he broke his arm in Quidditch and they gave him that thing to rebuild the bone, and it was very painful. It actually is painful for these infants to mineralize the bone, so pain management is part of their treatment. And while we're waiting for things to firm up, the chest and things, they often do require ventilatory support. And early on, it seemed like their only option was tracheostomy or PAP, but we decided to try high-flow nasal cannula in this patient, again, as a way to avoid sort of the mask on the face and do it. And it actually worked very, very well. So we're starting to think of high-flow nasal cannula as an alternative for our patients. So let's move away from obstructive sleep apnea and PAP. We sort of started with that case, and go to respiratory support in children with chronic respiratory failure. So worth repeating from the first slide. This is a very diverse group of patients. They may have advanced lung disease, so need help at night. They may have neuromotor disease or defects in their respiratory drive. So this is one of my patients with central congenital hypoventilation syndrome, who requires a ventilator at night. Their prognoses vary, as I've said. So some children you might expect to get better, some children will stay stable, and some children will unfortunately worsen. And often they do have multiple comorbidities. Some children, we do non-invasive, but some patients require a tracheostomy and invasive ventilation. And it's worth pointing out that children with tracheostomy, even despite their underlying disorders, whether it's a disorder we expect to get better or not, seem to be at very high risk for rehospitalization and even death. So there's a 21% mortality rate in children with tracheostomy, with a significant portion of that being accidental or unexpected. So it's not something we take lightly, and it's something, care of a tracheostomy at home really involves a lot of training and a lot of support. And then 40% are rehospitalized within the first 12 months after receiving the tracheostomy or discharge. This is a diagram I like to show because it just, again, makes, sort of points out how complex these children often are. And this was drawn by a parent of a pediatric patient reliant on chronic home invasive ventilation. And the inner circle is the family, and you just see all the different areas that this affects. So not only health, and again, remember, many of these children have comorbidities, but the support required, the support for siblings, how do you get to school, who supports these children in school, advocacy, legal and financial, recreation community, dealing with nurses, dealing with DME community. So I just always show this to point out again that this is a group of very complex children who often really rely on us as the professionals involved in their care to help navigate this huge web of issues. So why do we pursue chronic home ventilation in children with chronic lung disease or neuromuscular disease? Well, most of the studies have been done in children with neuromuscular disease, and we do know that pursuing chronic home ventilation may increase life expectancy. Studies have encouragingly showed that it improves quality of life, that children who choose, or families who choose to have chronic home ventilation, and it's not the answer for everyone, that eliminating hypoventilation and hypoxemia often eliminates symptoms that have been subtle, that families didn't even realize were related to the hypoventilation, and leads to improved sleep. So the children are more alert, more able to participate in activities. So often there are things that improve that maybe families or even the doctors didn't expect. And we do know that it can improve clinical status. It can lead to a reduction in hospital admissions, although you've sort of moved the hospital into the home. It's always worth keeping in mind. Improvement in children who are ventilated at night, sometimes see an improvement in daytime gas exchange. That may be due to muscle rest, maybe due to sort of resetting of the chemoreceptors to accept more normal gas exchange during the day. There are some thoughts and reports that by ventilating children, for example, with neuromuscular disease, you may help reduce the deformities of the chest and prevent sort of costovertebral joint contractures that we see in these kids that lead to worsening restriction as they get older. And some children report sort of improved cough efficiency due to improved lung volumes and maybe the respiratory muscle rest. Again, I will stress at this point that chronic home ventilation is not for everyone, and that families deserve to know the pluses and minuses of pursuing ventilation, especially when it's invasive ventilation. And that has to be placed in context of their family life, of the child's prognosis, of what they perceive as the child's quality of life and prognosis, and what their goals are for care. So this involves a discussion for sure. So just to go back to all of us as sleep professionals, we do in-laboratory ventilator titrations in our center. So this is not something that's universal across the country. There are many places still where children must go into hospitals to make sure their ventilator settings are still adequate. Similar to children being treated for OSA with CPAP, it is something we need to look at, think about at least yearly. Disease processes change, children grow, things change. So yearly at least. Again, it may be more often in younger patients, less often in older stable patients, but you want to think about it. There are benefits, we think, to in-laboratory ventilator titration. One is that we ask our patients to bring their home ventilators to the lab. We are able to use their home ventilators in the lab. And the first step is that our technicians and respiratory therapists can look at the ventilator and confirm the settings and that they match the orders that they received for the study. There was a study done in Spain where they looked at almost 300 patients receiving home mechanical ventilation and found that there were significant differences in a large number between the ventilator settings prescribed and the actual settings on the panel. And we have seen this as well. Orders you think have been acted on aren't acted on. There's confusion about the orders. We all know that there's many proprietary ways we name vent modes and things. And so it is good to have We do this in clinic, we do it in the lab, just another way to confirm what people are using at home. There are no standard protocols for doing ventilator titration in our center, so we ask the physicians who are ordering it to really list out, if the patient is hypercapnic, please do this, you know, because there is not a one-size-fits-all approach to this at all. We are fortunate in our main lab to have the support of respiratory therapists. I think this is the only way it works in our lab on vent nights. So the RTs are working closely with our sleep technicians, and the RTs are making the changes on the ventilator, right? This is the only way it can work. So we have set this up, and we do 2 vent nights a month, and it seems to work very well for our patients who would prefer to have their vents checked and titrated in a sleep lab versus an admission to the hospital. I mentioned again that we use the home ventilators, so that way too, we've sometimes brought patients in who have had concerns about their vents and we can't find something wrong or unusual alarms, so that we can observe that in that environment. And again, it's the sleep lab in our system has become another place where parents can ask questions to our technicians, to our RTs. So it's a chance to provide more support and ongoing education to our families. And when you look at studies of families whose children are on chronic respiratory support, the value of both support and ongoing education cannot be overemphasized. Reviewing techniques you think you know how to do, like suctioning a trach, or, you know, it doesn't hurt. We could all use it, and our parents feel they benefit from that. So AVAPs, similar to auto-titrating CPAP, is something kind of relatively newish in pediatrics, and there's very limited data. Most of, I think all of you have experience with AVAPs, which is a mode that provides a targeted tidal volume by adjusting pressures in a set range. There was a recent study that found that AVAPs actually improved hypercarbia in pediatric patients with hypoventilation who were having trouble being adequately treated on bi-level PAP. So this is non-invasive, and switched from bi-level to AVAPs, and they did see improvement in CO2. And they felt the effect was mostly an improved tidal volume using similar pressures. So we're starting to get a little more adventurous with AVAPs. We're always behind a little bit on some of these things in children, very paternalistic, close, but you know, there's some data to suggest it can be useful in some pediatric patients. So fortunately, many of our children who have tracheostomies at some point can become decannulated, can lose the trach, can, because of medical reasons, good medical reasons, not pull it out, be decannulated. So I wanted to again focus this talk on how our sleep lab is involved in that, since all of you are involved in sleep labs or in some way. And so in children, before decannulation, often a sleep study is recommended. So the protocols are not uniform, but when you look across the literature and across centers, many people prefer to have a capped study in the sleep lab, overnight study, before proceeding with decannulation. So there are some rules to these studies, again, when you look across protocols. The patients should be cleared for these studies by your otolaryngologist. I tell parents that we want to see what will happen if the patient's breathing through their nose and mouth and not through the trach. But if the trach is too big and we have a capped trach in the airway, you're essentially asking the child to breathe with a big hot dog in their airway, right? It's just blocking up. So we need to make sure that the tracheostomy, there's enough room around to allow adequate ventilation. And often that involves downsizing the tracheostomy on the night of the study. They need to be sure they can tolerate the capping awake. We don't cap children for the first time asleep in the sleep lab. And often otolaryngology needs to do an endoscopic evaluation of their airway to make sure there's not some obstructing lesion like a granuloma that should be removed before we try to do this at night. And when there was a recent study that came from actually here, where they looked at children with brain and spinal cord injuries, and 17% had concerning sleep studies despite a good endoscopic exam and a 24-hour cap trach trial. And that just points out, right, it's hard to pick up obstructive sleep apnea in the hospital when you have very brief DSATs and somebody's not staring at your monitor. So this, like I said, has become really fairly normal, or a normal thing in many, many centers across the country. And in one study looking at this, 65% of patients required some form of airway surgery because of an abnormal polysomnography and then looking before decannulation. So often granulomas need to be removed. Sometimes children are trached when they're very young, and then by the time they're ready for decannulation, they actually have big tonsils and adenoids and they have sleep apnea, and we didn't know because they had a trach in. So you really want to check that out before you pull the trach to make decannulation as successful as possible. And then lastly, another form of ventilatory support that we're seeing a bit more often in our labs, because we're also doing titration studies there, is diaphragm pacing. So in children, we see diaphragm pacing most commonly in congenital central hypoventilation syndrome and in spinal cord injury is where most of the research has been. And basically the children wear a transmitter, and that transmitter, we are able to adjust the voltage, which sort of affects the amplitude of the diaphragm movement and the respiratory rate. And the most common complication of diaphragm pacing is actually upper airway obstruction because of asynchronous contraction of the upper airway muscles in the diaphragm. So the diaphragm contracts, but nothing's telling the upper airway muscles to contract and open the airway. So many of our children who wear pacers actually still need trachs that they leave open at night. The alternative is some children wear pacers and PAP. So this is a complication. They've been working on ways to adjust the pacers to try and avoid that, sort of lengthening eye time or decreasing tidal volume in a way of sort of reducing the negative pressure or pull on the airway with variable success. So there's a little bit more literature coming out about the ability to decannulate children who are using diaphragm pacers, but many children still also have tracheostomies, but like the freedom from the ventilator. So I'd like to conclude by saying really thank you to all of you who help us care for children. As you can see, it really is it's a team sport. We need our respiratory therapists, our sleep technologists, our sleep professionals, our educators. We're so grateful to have all of you available to us for helping care for our patients. The families and our patients need our help and support. I think there's a lot of room in this field for advocacy. How can we expand and strengthen the resources available, get patients and families what they need? And we still need lots of research, continuing to expand treatment options. What are the best training programs for families, home nurses, our sleep teams, and lots of excitement. You know, if there's an upside to the COVID pandemic, you know, we've been able to use and be supported for using more telemedicine. For me, it's been fascinating to see what the rooms of my patients look like, how they're storing things, you know, how families manage vents and cough assists and suction machines and whatever, where BiPAP machines are, things like that. So really an interesting, I think, addition to our care panel. So I thank you all for your attention. We got you to lunch a little bit early, but I'm also happy to answer any questions.
Oh my God. Thank you, Laura. This was fantastic.
Oh my God, is that good?
No, I tell you, whatever we may see as a challenge with adults, with the kids, and then with the special need kids, this is a really, really an incredible labor, multidisciplinary that you do. You know, we had a case once. I got called and the tech told me, you need to read this sleep study now. I said, yeah, I'll get to it tomorrow morning. No, now. And it turned out it was an 8-year-old kid with an AHI of 138, which, by the way, when I saw yours at 323, I'm like, this kid was nothing. But he was really severe. And of course, a phone call started. The pediatrician, pediatric ENT, Anna, Lasso, etc. So he went for a CPAP titration, and at 19, the AHI was 58. So he saw him in clinic and put him on a trial of AVAPs, or with a trilogy, and for a week, and he did well. Then we brought him back to the lab for a titration because we use Respironics in our lab, and the AHI went to 9.7. And the ENT decided not to do tonsillectomy, adenotonsillectomy at that time, because the BMI was more than 50 and wanted him to lose a little bit more weight. But it was fantastic. And I'm glad we published it. And I'm glad that you mentioned that there's more use of IVAPs and AVAPs now in this group, especially with the auto EPAP feature that is very helpful. I wanted to, I saw that you mentioned the auto CPAP, and that was one of the questions I had. What, have you noticed also a lot of studies now pushing for home sleep studies in kids, and what's your opinion about that?
Yeah, so we still have not seen a lot of push for home sleep studies in kids. And I think there was an AASM statement not that many years ago not recommending home sleep studies for children. Where that cutoff is I guess, still a question. I mean, I think there's two reasons for that. One is that, so one of the criteria we believe for an adequate sleep study in a child is the measurement of CO2, right? Children across the board have less collapsible upper airways. They may or may not, I don't, but obstructive hypoventilation is a real pattern in children who may not collapse all the way, have these obstructive apneas. So without the use of end-tidal CO2, we may miss that pattern in children and underestimate the degree of upper airway obstruction. So that's one reason. Two is compliance, right? You guys have all read, or many of you have read pediatric sleep studies, right? Our techs are in there a lot, right? Attaching things, reattaching things. They are not often the most compliant patients. And then three is, we're often dealing with very small numbers, right? Like, an AHI of 3 is sleep apnea in a child. How sensitive really are some of these systems to sort of that degree? So the bottom line is we are not, at least in our group, we are not using home sleep studies. It hasn't been recommended by the AASM. So I don't have any experience with it, and we've been fortunate to be able to stay in the lab, which I think actually most parents appreciate because somebody else is attaching the cannulas. Yeah, and staying up all night. So
we have several questions. One is from Sylvan. How much attention is paid in your sleep clinic to orthodontic treatment for craniofacial factors such as maxillary expansion and mandibular reposition?
Yeah. So we actually worry about that quite a bit. So I don't consider myself an orthodontist, and I can't even play one on TV. But, we do, as I noted, especially in our kids who are already using PAP and stuff, I do worry. I start to see the development of underbites. You can see like things going in a lot of our preemie babies and stuff. We worry about the shape and the size of the palate. So we do encourage the parents, and we do work to get them to orthodontists and dentists as soon as possible. There's not great data on oral appliances for the treatment of OSA in children, but worrying about the shape of the mouth and the shape of the face in children using chronic home ventilation is something we think about, and we do ask parents to pursue dental care and orthodontic care early on, to have those professionals following the kids with us.
Okay, we have another question from Anita Naik. What do you suggest for a child after adenotonsillectomy, but still has mild to moderate OSA and some behavioral issues in attention, not obese.
Yeah. So to me, there's a little bit of a line between the mild and moderate. But so here's what it is. If I see a child who has residual OSA after adenotonsillectomy and they fall into the mild range, we could try some of the medical treatments for OSA that have been shown to be effective in children, right? So nasal steroids, the use of montelukast, maybe together. You want the right patient for that, somebody who's got an inflamed nose, someone who has allergies. But we have, there are studies showing that's effective and it can work for patients. The trick with that is you're never sure how long to go, do we do it months, do we do it weeks? So often I base it on, does the child feel better? Are they sleeping better? Do things happen? In the moderate range, and especially somebody who has a complication like behavioral, we would be thinking CPAP. We would try it, right? Especially if the parents are concerned about the behavioral issues. So, and maybe even in the mild range, it depends on the concern. So CPAP goes on the table then, but we have some medical things we can try.
So we have another question from John Brown, 2 questions. The first one is, how is diaphragmatic pacing tolerated in the pediatric population?
So it is actually tolerated well. I think the group that it's best studied in are the children with congenital central hypoventilation. It is used, actually it is tolerated well. The children like it, the families like it. Most of them though get it hoping they can get rid of the trach, because these children are almost universally trached as babies because we don't do it then. And they look at diaphragm pacing as they get older as a way to liberate from the vent. If they're on the vent 24 hours a day, they can be off during the day, makes for a more normal school life. If they're on the vent only at night, they can get rid of that. We tend not to pace 24 hours. So it's got to be the right patient for the right times. They like it. I think the problem we're having is that they really hope to get rid of the trach, and there's definitely a subset of patients that never do. So
the other question is, do you use end-tidal CO2 and transcutaneous CO2 monitoring together for hypoventilation in children?
Yes, on titration studies. So on diagnostic studies, we try just to use end-tidal. We're fortunate to have lots of transcutaneous monitors. So if we have a child who's not tolerating the cannula, we can throw a transcutaneous on to look at CO2. But for titration studies where, we worry about the effect of end-tidal of, being on a vent and things like that, then we put a transcutaneous on too.
I have a question for the high flow nasal cannula. Do you think that there would be a role in the future for fitting better the size of the cannula to the size of the nair to generate better pressure? Because it could make
so
a
then
difference.
Then I think one of the benefits of high flow nasal cannula is that you're not fully obstructing the nair. So the people who are really, because then you're just, to me, then you're close to nasal pillows, right? Like, except that it's a high flow, heated humidity system. So I don't know, I think what I like, and I'm not telling you we use a ton of high flow. It is really a very select group that we're trying it on and monitoring. I think where I've had the most success is really little babies that need something, and I'm trying to avoid doing a trach, and this seems to work. And then as soon as they get old enough, we actually often have to switch back to PAP, because it's not as, at least in my experience, it hasn't been quite as effective, but it's sometimes been enough to bridge people.
No, and I know also in your lecture, I know you have a limited amount of time, but could you comment for a minute before we break about negative pressure ventilators and Hayek and the possible concern of inducing obstructive sleep apnea? We've done a few studies in our labs with that, with pediatrics.
Yeah, so I have to admit, Monse, that I have never used a negative pressure ventilator. I know, I've seen the newer ones, which look much better than the whole iron lung thing. And of course, the risk is upper airway obstruction, similar to the diaphragm pacing, right? That you're just inducing that negative pressure without warning the upper airway. But I have no experience with it.
No, excellent. No, because we sometimes get questions about it, and we have to tell them this is not as simple. This can induce obstructive sleep apnea. You have to do a sleep study on them and all that. I get that question also from my adult patients. It's a dying therapy.
Yeah.
Yeah,
I just can't figure out who'd be exactly right for it, at least in my practice.
totally. Well, thank you very much, Dr. Sterni. Excellent talk, and I tell you, I would like to get together with you one-on-one and ask you 20 more questions.
I would love that.
Yes, thank you very much. We're going to take a break. John, do you want to make any announcement before we break until 2?
Monsi, Laura, nicely done. Great chemistry. I think you're right. It's time to give our audience a break. Thank you, everybody, for your attention. We will reconvene at 2 p.m. Our keynote speaker will be speaking at that time, Dr. Babak Maklaisi on obesity hypoventilation syndrome. Please remember to go to our exhibitor site. You can reach that site through the link that was pasted in by our conference organizer. That's right there, the MarylandSleepSociety.com/exhibitors/. Please click on the links there and you can go ahead and visit our gold and platinum sponsors. Thank you.